Hello everyone, welcome to the recall discussion of NEET PG 2025 medicine questions. Overall, pretty easy paper, and let's start the discussion. Coming to the first question, a 32-year-old female has presented with what symptom? A weakness involving the right arm. And this difficulty the patient experienced as a difficulty in kneading the dough, which means there is some sort of weakness involving the hand muscles and the forearm muscles. And on examination, there is atrophy, there is hypotonia, and sluggish deep tendon reflexes in the affected limb. So overall, the patient is presenting with certain motor features. The question is not about the diagnosis, but which of the following structures is most likely involved. What are the options? Posterior limb of internal capsule, left medullary pyramid, the right corticospinal tract in the cervical spinal cord, and option D, the anterior horn cells of the cervical spinal cord. Now, coming to the anatomical localization of the neurological deficit that the patient is having. We all know that patient has got weakness involving the right upper limb. And whenever you talk about weakness, what are the two types of weakness that we know about? UMN or upper motor neuron type of weakness and LMN, lower motor neuron type of weakness. So based on the history and examination, what do you think? Is this a UMN type of weakness or LMN type of weakness? Features like atrophy, hypotonia, and sluggish deep tendon reflexes are all telling you that the type of weakness that the patient is having is LMN type. That is the catch point here. Now, then have a look at the options. What is option A? Posterior limb of the internal capsule. Now, what goes through the posterior limb of the internal capsule? We have learned that through the genu and the anterior two-third of posterior limb, what passes? The corticospinal tract passes. So, the corticospinal tract is going through the posterior limb, and when there is a lesion involving the corticospinal tract, are you expecting UMN weakness or LMN weakness? UMN weakness. But in this question, we are not considering UMN weakness. I'm eliminating option A. Coming to option B, left medullary pyramid. Now, what goes through the left medullary pyramid? Again, corticospinal tract corresponding to UMN type of weakness. I'm eliminating that option also. Coming to the third option, right corticospinal tract. Again, the CST, corticospinal tract, this time in the cervical spinal cord, again is likely to produce UMN type of weakness. Now, what is the last option? Anterior horn cell. Now, anterior horn cell lesion is likely to produce LMN type of weakness. You can have atrophy, you can have hypotonia, you can have sluggish deep tendon reflexes. Hence, the answer for this question is going to be option D, anterior horn cells of the cervical spinal cord. That will be the answer here. Let's go to the next question. All right. So a patient in altered sensorium, okay, is detected to have a serum sodium of 95 milliequivalents per liter. So we know that the normal sodium levels are in the tune of 135 to 145 milliequivalents per liter, and hence this patient is having a severe hyponatremia, and probably that has contributed to the altered sensorium. And the patient was then treated with what? Hypertonic saline, probably because of the severe hyponatremia. And what happened later? After 24 hours, the serum sodium level increased. That's good, but increased to 111 milliequivalents per liter. What do you think? Good or bad? Well, there is a problem here. Now, I have always told you in my lectures, when you correct hyponatremia, okay, please make sure that do not too rapidly overcorrect, because in one day, that is over a span of 24 hours, you should not be going beyond 8 to 10 milliequivalents per liter per day in 24 hours. So you can see that the sodium level from 95 to 111. Okay, so almost a 16 milli equivalent rise has occurred in a single day. This is not good. This is too rapid correction of the sodium. Now let us see what has happened in this particular patient. After sodium correction, the neurological status has deteriorated. Now, in a patient with hyponatremia and altered sensorium, when you correct the sodium, you are expecting improvement in the sensorium. But what has happened here? There is a deterioration of the sensorium, right? So something has happened here. What could it be? So the question is, what is the next best step in the management? Is it MRI brain? Is it CSF analysis? Is it brainstem evoked potential, or is it EEG? Now, remember from my lectures, I've told you when there is too rapid correction of hyponatremia, this can result in some osmotic imbalance. Okay, and when there is an osmotic imbalance that develops acutely, this can result in a syndrome that is known as ODS. What is ODS? ODS is osmotic demyelination syndrome. Osmotic, as the term suggests, due to a sudden disturbance in the osmotic balance. Osmotic demyelination syndrome, this is abbreviated as ODS. Now, when ODS happens, what is the problem? This can result in damage to myelin. So there can be secondary demyelination. Osmotic demyelination can happen. This is a secondary demyelination. And this demyelination is highly likely to occur in which region of the brain? Especially the pons. Especially the pons. And because the demyelination predominantly involves the pons, it is also known as CPM. What is CPM? Central pontine myelinolysis. I repeat, central pontine myelinolysis. Central pontine myelinolysis. Okay, please also understand that though I said that pons is predominantly involved, it's not that only pons is involved. You can have extra pontine myelinolysis as well, but very commonly it involves the pons. Okay, so the diagnosis here is the osmotic demyelination syndrome, which is also referred to as central pontine myelinolysis because of the predilection to involve the pons. So we have got the diagnosis here, and we have understood the reason for the neurological deterioration. And for your knowledge, let me also tell you that when there is some sort of a central pontine myelinolysis that develops, this can also result in quadriplegia and coma as well. Okay, so sometimes the question can also mention about quadriplegia developing because of the extensive damage involving the long tracts of the pons. Okay, so diagnosis is clear, but the question is about the next best step. Okay, now when you look at the evaluation of central pontine myelinolysis, the most important part is to do the MRI brain. Okay, you will have to do the MRI brain. And what finding are you expecting in the MRI brain? Please have a look at this image. I've taken this image directly from the Harrison's textbook of internal medicine. So you can see here about the osmotic demyelination syndrome. This is axial T2 sequence of the brain, and you can see that in the region of pons there is demyelination. You can see hyperintensity involving the pons, and if you notice carefully, the hyperintensity has a peculiar pattern. So what do you call this pattern of hyperintensity that develops in the pons in the context of a central pontine myelinolysis? This is referred to as the trident sign. This is referred to as the trident sign. This is referred to as the trident sign. So you can see the mention in Harrison as well. The reason for this trident sign is a characteristic involvement of the transverse pontine fibers, and it actually selectively spares the descending corticospinal tracts. Okay, that is one characteristic pattern of affection, but that doesn't mean that all cases of osmotic demyelination syndrome will have the trident sign. Okay, you can have an extensive demyelination involving the pons without the trident sign as well, and sometimes it can damage the corticospinal tract as well. But I'm just telling you the name of one of the signs that can occur in the context of an osmotic demyelination syndrome. And you can see again, I am giving you the screenshot from Harrison, and you can see that the MRI is important for establishing the diagnosis. So the message from the question is, again given in Harrison, the therapy for restoration of severe hyponatremia should aim for gradual correction. And they're saying that as far as possible, not go beyond 8 milliequivalents per liter in a day within 24 hours, and not more than 15 milliequivalents per liter within 48 hours. So aim for a gradual correction. So for this particular question, there is no significant utility in performing a CSF analysis or a brainstem evoked potential or doing an EEG. So the answer will be option A, MRI brain. Okay, right. Let's go to the next question. Right. So what is the next question? A 55-year-old man with a long-standing history of diabetes mellitus. So long duration of illness. Patient has presented with numbness and tingling in both feet. So long duration diabetes patient presenting with sensory symptoms in both feet, you're definitely thinking about diabetic neuropathy. And this is like any other diabetic neuropathy, first involving the lower limbs, because we know that diabetic neuropathy has the typical glove and stocking pattern. Glove and stocking pattern. Though the name is glove and stocking pattern, the area that is first involved is the glove region or the stocking region. The stocking region. Okay. So the patient has developed a diabetic neuropathy, and on examination, you can see that the deep tendon reflexes in both the lower limbs are reduced. Which of the following is the most likely cause of the patient's symptoms is what the question is asking you. So it is a diabetic neuropathy, I told you. Look at option A, autonomic neuropathy. Now, diabetes mellitus, diabetic neuropathy can have autonomic manifestations. But if you look at the question, you're not seeing any features of autonomic dysfunction, nor is there any mention of orthostatic hypotension, no mention of any sort of erectile dysfunction, no gastroparesis or diarrhea, no autonomic symptoms being mentioned. So I'm eliminating that option. The next option being mononeuropathy. You can very well see that the manifestations has happened in both the feet and probably symmetrically in a glove and stocking pattern. And the reason for this glove and stocking pattern is something that I have taught you in my lectures. What is it called as? Length dependent neuropathy. Length dependent neuropathy with the longest axons being affected first, which is why the lower limb is affected first. So it is not going to be a mononeuropathy. Okay. So diabetes mellitus can produce mononeuropathy, but that is not what we are seeing in the question here. Next is bilateral distal symmetric polyneuropathy, which is the common pattern of neuropathy that you would associate with diabetes mellitus. So diabetes mellitus is a sensory motor neuropathy, more predominantly sensory compared to that of motor. So here the patient is having a definite sensory involvement, as well as you can see the reflex arc is also involved due to the peripheral nerve involvement. And coming to option B, it is acute motor axonal neuropathy, which is AMAN, which is actually a variant of Guillain-Barré syndrome. So a motor variant. So that is also not the answer. The answer for this question is going to be option C, bilateral distal symmetric polyneuropathy, right? Let's go to the next question. Okay, so no exam is complete without a question on stroke, right? So here is a question on stroke. A 70-year-old patient with a history of hypertension and atrial fibrillation. Okay, so whenever you have got a stroke in the context of atrial fibrillation, have a special look at it. So patient is presenting with an acute onset weakness of right side of the body and aphasia. So acute onset and hemiplegia with aphasia. So definitely it is likely to be a vascular insult, and the symptoms actually has begun 2 hours ago, right? Okay. So that itself is telling me that the patient is in the window period for thrombolysis, and definitely the revascularization is possible. The non-contrast CT shows no evidence of hemorrhage. So we have already ruled out hemorrhage based on the non-contrast CT scan. The question is, what is the next best step in the management? Option A, administration of intravenous recombinant tissue plasminogen activator like alteplase, which is definitely in consideration as the patient is a candidate for thrombolysis, and I'm not seeing any active contraindication as well. What about role of a transesophageal echocardiogram? Look, the patient is having atrial fibrillation, but the question is about what is the next best step. Do you think that doing a transesophageal echocardiogram is going to change the immediate management? No. See, when patient comes with even an embolic stroke, doing a transesophageal echo would help, but not in the immediate management, right? So it is not going to change your management strategies in the acute phase. So transesophageal echocardiogram is not right. Low molecular weight heparin. Look, anticoagulation can be considered in this patient, but again, that is not the next best step. Please understand, even for an embolic stroke, when the patient presents within the window period, the first step in the management is to go for the revascularization strategies, either a thrombolysis or a mechanical thrombectomy, depending on the eligibility. So, low molecular weight heparin is not something that I would consider. Coming to the next option, carotid Doppler ultrasound. The utility of carotid Doppler ultrasound in the evaluation of stroke is to look for a carotid stenosis due to a significant atherosclerosis. But that again is mostly for deciding whether the patient needs a carotid end arterectomy or a carotid artery stenting, which is again for the secondary prophylaxis. Again, does not influence the acute management. So I'm eliminating that option as well. So what is going to be the answer for this question? Option A, right? Okay, let's proceed to the next question. Right. So this is a question which is going to tickle your nerves of your central nervous system. A 35-year-old woman presents with a history of migraine was initially on over-the-counter NSAIDs. Okay, so she was keeping on taking NSAIDs, but since there was not adequate relief, she is currently using sumatriptan for acute attacks. Obviously, more severe migraine might require triptan, but watch out. The patient reports experiencing chest tightness after taking medication. Now, my dear children, you guys, please tell me, when a patient develops a chest tightness after taking triptan, what are you considering? I am considering the possibility of coronary vasospasm. I am considering the possibility of coronary vasospasm. Okay, coronary vasospasm, because triptans can produce coronary vasospasm, especially in susceptible individuals. And the patient is also having a family history, that is, father is having a history of coronary artery disease. The question is, what is the most appropriate agent to add for migraine prophylaxis? So the question is regarding the prophylactic agent. So I can straight away eliminate two options here. One is naratriptan, which is another triptan, which is again not an agent for migraine prophylaxis. And ergotamine is again an agent for acute treatment of migraine and not migraine prophylaxis. I'm left with two options, propranolol and topiramate. Now, we all know that the drug of choice for migraine prophylaxis is propranolol. So, you are tempted to go for propranolol here. But again, when I heard the question for the first time from my students, I also heard a partial version of the question only. So, I also thought that maybe this could be propranolol. But once I got the full version from the students, I'm thinking otherwise. I'll tell you why. Now, propranolol, we know that is contraindicated in certain scenarios. Maybe when the patient is having bronchial asthma, no such mention of bronchial asthma in the question. Severe depression is a contraindication for beta blocker. Again, no mention in the question. But a vasospasm, a coronary vasospasm, is again to be considered as a contraindication for use of beta blockers in migraine. Do you want a reference? Yes, let me show you. So you can see this. This is from the European Society of Cardiology document on the drugs for prophylaxis of migraine. And as always, beta blockers a preferred choice. And you can see here the concerns in patients with cardiovascular disease. Beta blockers are contraindicated in patients with epicardial coronary spasms. Now, this is very, very important. So, since in the question there is a specific mention that intake of triptan has resulted in chest tightness, I am strongly considering the possibility of coronary vasospasm, or I can say that this patient is predisposed to develop coronary vasospasm, and because of that I'm not favoring propranolol, because I've got another option, topiramate, which is again a drug that is used for migraine prophylaxis, and it is a commonly used drug, and there is no other data that is given in the question which is a contraindication to use of topiramate. So when you look at the question with the options, I feel the better answer will be topiramate. Okay, I've told you the reason. There is a specific mention in the question of the patient having a probable coronary vasospasm, because of which you are preferring topiramate over propranolol in this particular case. All right. Okay. So coming to the next question. Which drug is used for the prophylaxis of meningococcal meningitis? Pretty simple, straightforward question. Among the options, rifampicin. Again, I have taught you in my lectures also regarding the agents used for the prophylaxis of meningococcal meningitis. But just for a reference, I am showing you the Harrison screenshot as well. So in case of the meningococcal meningitis, please understand the index case and the close contacts, okay, should be receiving chemoprophylaxis. So chemoprophylaxis with either the rifampicin, okay, can be given as oral drug, but again you have got alternative options like ceftriaxone or maybe azithromycin. So please also understand that rifampicin is not the sole agent. You can also consider azithromycin or ceftriaxone. As per recent literature, the intramuscular dose of ceftriaxone is more effective than oral rifampicin in the prophylaxis of meningococcal meningitis. But in this particular question, the examiner has not troubled us, and they have just put the option pretty straightforward. The answer is going to be rifampicin. Okay, right. Let's go to the next question. All right, and this is a ditto repeat of the previous year NEET PG 2024 question. Straight question with the same options. What is preferred in the evaluation of syndromic meningitis? First of all, you have to understand what is syndromic meningitis. Syndromic meningitis means imagine a patient presenting to you with the characteristic features of meningitis like fever, headache, and neck stiffness, and you exactly do not know whether the etiology is bacterial, viral, fungal. So you are suspecting a wide range of etiologies. Now, in such a case where you have understood it is a meningitis syndrome and you have got to evaluate for multiple pathogens simultaneously, that is when you go for this investigation known as multiplex PCR, which can at a time within a short span of 1 to 2 hours can detect almost 14 pathogens, which includes bacteria, virus, fungi. So that is called multiplex PCR. Definitely you are not considering other options. Look at the first option, single pathogen. Are you going to evaluate for a single pathogen in a syndromic meningitis? No. So the answer for this question is going to be multiplex PCR, that is preferred in the evaluation of syndromic meningitis. Okay, right. Let us go to the next question. Based on the imaging, what is the diagnosis? Again, a question integrating neurology with radiology. So you have got a contrast enhanced MRI, number one. Number two, the lesion is pretty much visible in the right hemisphere. And number three, the lesion is homogeneously enhancing with contrast. Yes, you can see that, all the entirety of the lesion is enhancing with contrast. Fourth point, very important. The fourth point, can you see there is a slight extension of contrast here beyond this boundary? Okay, so this is what is referred to as the dural tail sign. What did I say? Dural tail sign. The imaging is suggestive of dural tail sign. Dural tail sign. Let me show you the reference as well of the dural tail sign. So dural tail sign, the reference is from Bradley's textbook of neurology, which is the standard textbook of neurology. So dural tail sign refers to the linear extension of the enhancement along the dura. Extension of the enhancement, which means, if you look at the lesion, there is a slight extension, right? A slight extension. So this extension in the form of a tail, that is what is called the dural tail sign. Okay, not 100% specific, but again, more likely to suggest a pathology like meningioma. So the answer for this question is going to be option C, that is meningioma, right? Okay, let's go to the next question. So we have discussed the neurology questions, and I think it's time we start with the cardiology questions. 70-year-old male, so elderly male, presenting to the emergency department with complaints of dyspnea and palpitation since the last 4 hours. Okay, since the last 4 hours. ECG was suggestive of atrial fibrillation. So an elderly male presenting with dyspnea and palpitations with a new onset atrial fibrillation. Correct? It's a new onset AF. New onset, because when the duration of the AF onset is less than 48 hours, you call it to be new onset AF. So elderly with new onset AF, what is the next best step in the management? Now, had the question made any sort of mention about hemodynamic instability, if the patient was in shock, definitely emergency cardioversion would have been an option, but that is not mentioned in the question. So this is a hemodynamically stable atrial fibrillation. That is what I would consider. Now, when you have got a hemodynamically stable AF, again, the options are either a rate control or rhythm control, right? Rate control, you can use drugs like, say, beta blockers for the control of rate, or maybe calcium channel blockers, which are the non-dihydropyridine calcium channel blockers. Or you can go for rhythm control strategies, again with cardioversion also can be considered. But when you have an elderly male, what are you going to consider here? Rate control or rhythm control? What is a safer strategy? It is the rate control strategy that is preferred over the rhythm control strategy. So my answer for this question will be option B, to control the ventricular rate, which would definitely help me in relieving the immediate symptoms of the patient. So emergency cardioversion not being considered. Okay, I told you why. No mention of hemodynamic instability, and even hemodynamically stable atrial fibrillation also you can consider for emergency cardioversion as a part of rhythm control strategy. But again, not in this case, the reason I've just told you. And what about the option C, the echocardiography to look for a left atrial clot? So you will consider a left atrial clot mostly in the context of an AF that has been persistent for more than 48 hours, because thrombus formation is more likely to occur when the atrial fibrillation has persisted beyond 48 hours. So I'm eliminating that option as well. Next is starting the low molecular weight heparin. Again, atrial fibrillation patient, you should be considering anticoagulation. But the question is on the next best step in the management. So I've got to control the symptoms of the patient, and hence the best answer will be option B, that is the control of the ventricular rate. Option B is the best answer here. Okay, right. So coming to the next question. A 45-year-old male, female, presented with a 6-month history of dyspnea and palpitation. So relatively longer duration of symptoms, 6 months, dyspnea and palpitation. On examination, BP and oxygen saturation normal. Pulse was irregularly irregular. Okay, so could be an atrial fibrillation. We don't know. Let us see. JVP was elevated. So dyspnea with elevated JVP with a left parasternal heave and tender hepatomegaly. So the last few pieces of information has already told me one thing. And what is that? The patient is having features of right heart failure, right? Okay. On auscultation, there is a mid-diastolic murmur heard at the apex. The patient also has a history of acute rheumatic fever. So which means we are probably having a patient with a rheumatic heart disease leading on to a mitral stenosis, because MS is known to produce the mid-diastolic murmur, and MS patients can develop atrial fibrillation as well. So this is MS with AF, and the patient has developed right heart failure probably because of the pulmonary hypertension pulmonary hypertension, and the patient has a left parasternal heave, again telling you that there is evidence of right ventricular hypertrophy as well. The question is, which of the following statements is false? Regarding the first option, she will have an increased risk of developing stroke. What do you think? Obviously, it's a true statement. A patient with RHD-MS having atrial fibrillation is highly likely to develop a clot in the left atrium, and the clot is likely to dislodge and it can definitely produce a stroke. So that is definitely a true statement. That is not going to be the answer. Next option, absent A wave on JVP. We very well know that atrial fibrillation can have absent A wave on JVP. I'm eliminating that option as well. Next option, the patient has features of right ventricular hypertrophy, which has again been mentioned. There is left parasternal heave. I'm eliminating that option as well. What is the last option? Presystolic accentuation of the mid-diastolic murmur will be present. Now, when you have a patient with mitral stenosis with a mid-diastolic murmur, one of the properties of the murmur is that it can have a pre-systolic accentuation. So there can be some sort of increase in the intensity of murmur just before the systole. So the late phase of ventricular diastole, or the phase just before the systole, is characterized by something that is known as atrial kick, because there is a active contraction involving the left atrium to eject out the remaining blood. So because of the atrial kick or the forceful atrial contraction, there can be a presystolic accentuation of the mid-diastolic murmur. So definitely patients with MS can have presystolic accentuation of the mid-diastolic murmur. But there is a problem here. What is that scenario where you will not get such sort of a presystolic accentuation that happens in the context of atrial fibrillation? So because the atrial kick is necessary for the presystolic accentuation, when you have a disorganized atrial musculature contraction in atrial fibrillation, this presystolic accentuation will not be present. So the answer for this question is going to be option D. Always remember, in a patient with AF and RHDMS, you are not going to get the expected presystolic accentuation, and that is going to be the correct answer for this question. Okay, right. Coming to this question, 55-year-old male patient presents with episodes of shortness of breath and palpitations. An ECG confirms paroxysmal supraventricular tachycardia. So for NEET PG, PSVT is always a hot favorite topic. And what is the question asking you? What is the most appropriate option for long-term prophylactic treatment? Now look at the options: oral verapamil, IV adenosine, IV espadol, and oral phenytoin. So we know that for PSVT, the acute termination IV adenosine is considered to be the drug of choice. But the question is very specific on prevention, long-term prophylactic treatment. I am eliminating IV adenosine here. Okay. I am also eliminating IV esmolol here. And we know that oral phenytoin, though phenytoin is an anti-epileptic, which has got certain anti-arrhythmic potential as well, but it's not something that is preferred in the paroxysmal supraventricular tachycardia. But yes, oral verapamil, which is a non-dihydropyridine calcium channel blocker, is a preferred agent for long-term prophylaxis against recurrence of PSVT. My answer is point B, option A, oral verapamil. Okay, right. Let's go to the next question. A patient with type 2 diabetes mellitus, currently on insulin and metformin, has an HbA1c of 8.3. So we are thinking about an uncontrolled diabetes, okay? And patient has features of chronic heart failure as well. And this is heart failure with reduced ejection fraction, because in the question they had specifically mentioned that ejection fraction is less than 35 percentage. The question is, what is the next best add-on therapy? Obviously, the next best add-on therapy is going to be an agent that is going to bring the blood sugar under control, and also an agent that has got an additional cardioprotective property. So if you remember this slide from my lectures on the treatment of chronic heart failure, I told you that heart failure with reduced ejection fraction is there. Heart failure with preserved ejection fraction is there. When the ejection fraction is less than or equal to 40%, you call it heart failure with reduced ejection fraction. More than 50 percentage, heart failure with preserved ejection fraction. And you can also have heart failure with a mildly reduced ejection fraction in the range of 40 to 50. And in patients with heart failure with reduced ejection fraction, as given in question, I have always told you that there are four pillars of treatment, which are definitely having some mortality benefits as well. The first group of drugs is the ARNI, that is the angiotensin receptor blocker, neprilysin inhibitor. If not available, you can go for AC inhibitors or ARB. The second pillar is beta blocker, the third pillar is MRA, and the fourth pillar is SGLT2 inhibitor. Among the beta blockers, the MBC beta blockers, metoprolol, bisoprolol, and carvedilol are useful. And you can see here, I am making a special emphasis on SGLT2 inhibitor. So this is a slide that I've taught you in my class. But for the time being, I'm just focusing on SGLT2 inhibitors alone. Why? Because if you look at the option, the only SGLT2 inhibitor is empagliflozin, but the other agents are not having any added benefit, though all of them are used in diabetes management. If you look at the options, if you look at pioglitazone we already know is likely to cause fluid retention. And in a patient with heart failure, do you want an agent that causes fluid retention? Glibenclamide and then sitagliptin, which is DPP4 inhibitors, again, not much benefit in case of heart failure with reduced ejection fraction. So why I've gone for option C is because of the dual benefit of the drug empagliflozin, which is a SGLT2 inhibitor in this particular case. Okay, right. Let us go to the next question. A critically ill patient with COVID-19 is admitted to the ICU and requires mechanical ventilation. The PaO2 to FiO2 ratio is 100, which is consistent with severe acute respiratory distress syndrome. I'm sure that you remember about the severity of ARDS that I've taught you in my lectures based on the PaO2 to FiO2 ratio. So anything which is coming in the range of less than or equal to 100 will come under the purview of severe acute respiratory distress syndrome. But what is the question? Which of the following ventilatory strategies is most appropriate for managing this patient? I've always told you in my lectures that the ventilator management strategies of ARDS is very, very important, and you have to know it thoroughly. And when it comes to the options, you can see that high PEEP with low tidal volume, high PEEP, high tidal volume, low PEEP, low tidal volume, low PEEP, and high tidal volume. I've always told you in my lectures, one of the most important, I repeat, most important ventilatory strategy in ARDS is low tidal volume. So I'm already eliminating options that has high tidal volume. So the low tidal volume ventilation, which means, unlike the conventional 12 mg per kg, you're going for a low tidal volume, 6 ml per kg of predicted body weight is what you are going for. Because if you go for high tidal volume in ARDS, there is always a chance of volume trauma. There is always a chance of volume trauma, which is why I'm going for a low tidal volume ventilation. Now, should I go for high PEEP or low PEEP? Now, at the end of expiration, you have to have a positive pressure or it can result in atelectasis. Okay. So if you look at this screenshot from Harrison's textbook, you can see that in the ventilator strategies for the management of ARDS, you have to prevent number one, volume trauma. And how do you prevent volume trauma? Low tidal volume ventilation, because volume trauma occurs from excess tidal volume. Okay. And another point that you want to prevent is atelectic trauma that occurs due to a alveolar collapse. So this alveolar collapse can be prevented by giving a high PEEP. So for this particular question, the answer is going to be option A, high PEEP with a low tidal volume. Okay, so that is going to be the answer. Okay, right. Let's go to the next question. Okay. Meanwhile, you can also see the evidence-based recommendation strategies for ARDS, and you can very well notice that the best recommendation or the level A recommendation is for low tidal volume ventilation. Okay. Coming to the next question, a patient with asthma is currently being treated with salbutamol and ipratropium bromide. So what is salbutamol? It is a SABA, short-acting beta-2 agonist. And what is ipratropium bromide? It is SAMA, short-acting muscarinic antagonist. Okay. So the patient now reports frequent nocturnal symptoms, which means the symptoms are not under control. What is the most appropriate next step in the management? Okay. So what should be done? So, having said that, I think the management of the patient so far is not according to the protocol, and I'm sure that my students already know about the management of bronchial asthma as per the GINA guidelines. So this is not the recommended strategy what has been followed in this particular patient so far, but they're asking you what is the next step, or you want to go for the appropriate next step. Is it increasing the frequency of salbutamol? Is it adding montelukast at night? Is it adding oral corticosteroids? Or is it switching to an inhaled corticosteroid plus a long-acting beta-2 agonist? What do you think has to be done? Now, that is what you have got to do. You have to go for an ICS-LABA combination. If you remember, the track-based management of the bronchial asthma. Okay, so you can see that as a reliever, you've got as needed low dose ICS formoterol, and even for the maintenance therapy, you're preferring the combination of ICS formoterol. Okay, so ICS formoterol is nothing but an inhaled corticosteroid and a long-acting beta-2 agonist, which is the preferred step in the management of the bronchial asthma. So I've got to switch to an inhaled corticosteroid, because since the patient is having frequent nocturnal symptoms, you will have to not only give a bronchodilator, you have also to give an anti-inflammatory agent like a corticosteroid, which is why the answer is going to be option D. Okay, right. Coming to another question, which is again something that we discussed in the class about the mechanism of action of benralizumab. So benralizumab is acting on the interleukin 5. To be more specific, it is acting on the interleukin 5 receptor. So you can see this is from my lecture on the various add-on controller medications used in bronchial asthma, and benralizumab is acting on the interleukin 5, to be more specific, interleukin 5 receptor. Okay, right. So next time they might ask a question on maybe the anti-TSLP like tezepelumab. So watch out for that as well, right? Okay, let's go to the next question. A 55-year-old woman presents with acute respiratory distress and hemoptysis on day 7 after a knee replacement surgery. So once you've had a major surgery that is interfering with your mobilization and you've got a prolonged period of immobilization, when a patient develops acute respiratory distress with hemoptysis, what are you thinking of? You are thinking of a possibility of a pulmonary embolism. So the patient's respiratory rate is high, 28. So there is tachypnea, there is tachycardia. Strongly suspecting pulmonary embolism in this case. What is the most appropriate investigation to confirm the diagnosis? Simple question, CT pulmonary angiography. If any one of you is thinking of writing D dimer, I'm just going to give you a blow. It's not D dimer. Why? Because the utility of D dimer in the evaluation of pulmonary embolism is only in low probability cases as a screening test. What do you think? Is this a low probability case or a high probability case? Do you want to do a D dimer and again waste some time? No. It is not a specific investigation also. So what you have got to understand is you look for CT pulmonary angiography, and so D dimer, not chest X-rays. Again, you can have either a normal finding or maybe some finding like Pella sign, Hampton sum, but these are non-specific. It is not going to confirm the diagnosis in any sense. V by Q ratio, V by Q scan is done in cases where maybe the contrast is contraindicated, like pregnancy, renal failure. That is only when you will consider V by Q scan than the CT pulmonary angiography. For this question, the answer is going to be option C, CT pulmonary angiography. Okay, right. Coming to the next question. A 55-year-old patient presents with shortness of breath. This time, two questions were asked based on ABG analysis, and both of them were relatively simple. So, the ABG analysis reveals a pH of 7.22, PaCO2 of 66, bicarbonate of 28. The question is, what is the most likely acid base disorder? So, if you put the arrows, you can see that pH, a down arrow, then PaCO2, the arrow is going up, and bicarbonate also arrow is going up. So in the context of acidosis, so already eliminating all the alkalosis nonsense options here, acidosis, and when the change in pH in relation to the PCO2 and bicarbonate is in opposite direction, you're going to think about a respiratory acidosis. Answer is going to be option C, right? Okay. Coming to the next question, another simple one. 50-year-old man presents to the emergency department with altered sensorium, hypotension, and shortness of breath. The arterial blood gas reveals a pH of 7.2, PaCO2 of 44, a PaO2 of 54, bicarbonate of 16, and a base excess of minus 12. Serum electrolytes show a sodium of 130 and chloride of 84. Based on the following findings, what is the most likely acid-base disturbance? So pH of 7.2 is telling that there is acidosis. Okay, there is acidosis. And what is the reason for the acidosis? You can see that there is a significantly reduced levels of bicarbonate. Okay, PoCO2 is only mildly increased. So it is not going to be a respiratory acidosis. So it is going to be a metabolic acidosis here. And they are asking about the anion gap as well. So sodium is 130 and the chloride is 84. The bicarbonate is 16. So the anion gap is 130, the sodium minus chloride plus bicarbonate. So 130 minus 100, which is going to be 30. So the answer for this question is going to be metabolic acidosis with an anion gap of 30, right? Okay. Coming to the next question. A patient presents with acute knee pain and joint swelling. Okay, so the next set of questions are from cardiology. We have just seen the questions from pulmonology and acid-base balance. So moving to rheumatology. Okay, moving to rheumatology. The patient presents with acute knee pain and joint swelling. Synovial fluid analysis shows rhomboid shaped crystals that exhibit positive birefringence. So acute knee pain, okay, rhomboid crystals, positive birefringence. What are you thinking about? Pseudo gout. Gout can involve knee joint, but more commonly, the first joint involved is first metatarsophalangeal. But over and above that, the gout is negatively birefringent needle-shaped crystals. That is not what I am thinking about. And rheumatoid arthritis and amyloidosis again is not going to present with the following synovial fluid analysis. You are going to have an inflammatory synovial fluid in rheumatoid arthritis, but that is not going to show any sort of rhomboid crystal, because only the gout and the pseudo gout come under the purview of crystal induced arthropathies. Remember, I've taught you in my lectures about crystal induced arthropathies like gout, like pseudo gout, calcium oxalate deposition disease, calcium hydroxyapatite deposition disease. For this question, the answer is going to be option B, a pseudo gout, wherein you have got the deposition of calcium pyrophosphate dihydrate. Okay, right. Next question, again from rheumatology. Patient presents with prolonged morning stiffness and is found to be positive for anti-CCP antibodies. Again, giving you a clinical possibility of rheumatoid arthritis. Which of the following histopathological findings is most characteristic of the underlying disease, which is probably rheumatoid arthritis? Option A, synovial inflammation with pannus formation. Yes, we know that synovitis is a characteristic pathological finding in rheumatoid arthritis, and you can also have pannus formation. That is definitely going to be the answer. But again, I would like to go through the other options. Cartilage degeneration with osteophyte formation. That is probably about osteoarthritis. That is not going to be the answer. Subepidermal blister with IgA deposits. Again, no, you're probably discussing about dermatitis herpetiformis. Tophi containing monosodium urate crystals. No, again, you are thinking about gout. So again, option A is going to be the answer for this question, right? Okay. Coming to the next question, again from rheumatology. A patient presents with progressive skin thickening. Lab evaluation reveals an ANA positivity along with anti-SCL70. And anti-SCL70 is nothing but the anti-topoisomerase 1 antibodies. Question is, which of the following clinical manifestations is most strongly associated with this antibody? Okay. So what is the clinical diagnosis here? Skin thickening, ANA positivity. It is definitely going to be systemic sclerosis. It is definitely going to be systemic sclerosis. And the antibody positivity tells you that this is probably a diffuse cutaneous systemic sclerosis. And a patient with diffuse cutaneous systemic sclerosis with a positive anti-SCL70, I've told you that is a high risk of developing interstitial lung disease. At the same time, if the question mentioned that there was a positivity of anti-RNA polymerase 3, so anti-RNA polymerase 3, if that is positive, though it is not given in the options, but again, maybe for a future question, you have to understand that this has a higher risk of scleroderma renal crisis. Scleroderma renal crisis. Okay, this is what you should be understanding. Okay, right. Okay, let's go to the next question. A 26-year-old man presents with chronic low back pain that is worse in the morning and improves with physical activity. I've always told you, when you have a chronic low back pain in a young adult, it could very well be a mechanical back pain. But if there is a mention that the pain improves with physical activity, a mechanical low back pain would worsen with physical activity. But if there is a mention of improvement with physical activity, you have to consider strongly a diagnosis of ankylosing spondylitis, which is again substantiated by the presence of an extra-articular manifestation that can be seen in patients with ankylosing spondylitis. In fact, the most common extra-articular manifestation, which is anterior uveitis. But X-ray of the sacroiliac joint is reported as normal. You very well know that in ankylosing spondylitis, one of the early radiological changes is sacroiliitis. Now, what do you think? Does this point take the diagnosis away from ankylosing spondylitis? No, because I've told you in early cases, X-ray may not show changes. That is the case, if you still strongly suspect ankylosing spondylitis, you will have to go for an MRI of the sacroiliac joint so as to demonstrate the bone marrow edema. So as to demonstrate the bone marrow edema. Okay, so the answer for this question is going to be option A, MRI of the sacroiliac joint, right? Okay, thank you. Next question, let's go for that. Okay, but again, do you want to go to the other options? Anti-CCP antibody, not considering rheumatoid, bone scan, again, not of much utility in ankylosing spondylitis. Ultrasound, always MRI is better than ultrasound. That's what I want to tell you. Okay, right. Coming to the next question, a young adult presents with tall stature, disproportionately long arm span compared to height. You're already thinking about Marfan syndrome. On examination, pigeon chest deformity, your suspicion is again strengthened. And long, slender fingers, arachnodactyly again strengthens your suspicion. Ophthalmological evaluation shows subluxation of the crystalline lens, which is ectopia lentis, which again tells you the diagnosis is Marfan syndrome. The question is on the genetics of Marfan's. We know it is autosomal dominant inherited condition affecting which gene? It is a fibrilin 1 gene. Next question, please. Okay. A 45-year-old woman presents with a 6-month history of dry mouth and dry eyes. So patient is presenting with Zika symptoms. The patient is presenting with Zika symptoms. So laboratory evaluation reveals that she is ANA positive, and anti-Rho positive, and anti-La positive. So what is going to be the clinical suspicion here? It is Sjogren's syndrome. Okay, it is Sjogren's syndrome. Sjogren's syndrome. So what's the question? Which of the following findings is most commonly associated with this condition? So is it recurrent oral ulcers? Recurrent oral ulcers, again, more suggestive of Behçet's. So I'm not considering that. Destruction of lacrimal and salivary glands by lymphocytic infiltration, which very well correlates with the pathology of Sjogren's syndrome. That can very well be the answer. Acute glomerulonephritis, I don't think so. When it comes to renal involvement in Sjogren's syndrome, it can either be a interstitial nephritis or it can be a renal tubular acidosis, which is the distal RTA. Glomerulonephritis is unlikely a feature of Sjogren's syndrome. Malar rash and arthritis. Arthritis can occur in Sjogren's syndrome, but again, malar rash is not that much favoring. It is in SLE only. And we have got an obvious answer also of option B. That is going to be my answer. A mechanism of action of pegloticase. So pegloticase is recombinant uricase or recombinant urate oxidase. So this can oxidize the uric acid to the water soluble allantoin. So what is the answer? Option A, oxidizes uric acid. Patient presents with 1-month history of cough and respiratory discomfort. On examination, there is evidence of hilar lymphadenopathy. Lymph node biopsy reveals granulomas. So granulomas with stellate inclusions. Pneumonia is not likely to produce granulomas. So I'm already eliminating that. Tuberculosis can produce granuloma, sarcoidosis can have granuloma, histoplasmosis can have granuloma. But when you have got mention of stellate inclusions, it is likely to be asteroid bodies, what the examiner has meant. So asteroid bodies are likely to occur in this case. So this question answer is option B. Tuberculosis will have caseous necrosis. So caseating granuloma mention would be there. Okay, and yeah, that's it. Answer is sarcoidosis. A patient with recurrent infections and bleeding undergoes bone marrow aspiration, which shows abnormal myeloblast as seen in the image. Which cytogenetic abnormality is associated with this condition? Pretty simple, straightforward. You are seeing the OR rods. And when you have got OR rods, you're considering AML M3, acute promyelocytic leukemia, which is associated with translocation 1517. Option D is the answer. A 45-year-old man presents with fatigue and pallor following surgical resection of the ileum. Laboratory studies show a hemoglobin of 9 and an MCV, again suggestive of macrocytosis as it is increased. Which of the following is the likely cause of his anemia? So we are already having macrocytosis. Please eliminate sideroblastic anemia and iron deficiency. Vitamin B12 and folic acid both can have macrocytosis, but since the question specifically mentions a surgical resection of the ileum, and since vitamin B12 is absorbed in the ileum, the answer is going to be vitamin B12 deficiency. Remember, folate is absorbed in the duodenum as well as the jejunum. Okay, here there is a history of surgical resection of ileum. It could very well be vitamin B12 deficiency. A 12-year-old boy presents with fatigue, mild jaundice, and splenomegaly. Laboratory evaluation reveals increased MCHC. Father had a similar history of recurrent jaundice and splenomegaly. So, fatigue, jaundice, splenomegaly. We are considering a hemolytic anemia, increased MCHC. So, probably you've got spirocytes. Now, if you look at the options, okay, if you look at the options, thalassemia minor, hereditary spirocytosis, iron deficiency anemia, sickle cell anemia. So you've got increased MCHC. You're already eliminating options like, iron deficiency anemia, thalassemia minor, sickle cell anemia. And especially when there is a family history also, you're considering an inherited condition, okay, a familial condition like hereditary spirocytosis. Option B, box will be the answer. Okay, right. 15-year-old presented to the OPD with breathing difficulty. Now, the patient has come with some symptom of breathing difficulty. He is very tall, as an enlarged jaw. So probably, the patient is having some sort of acromegaly, and breathing difficulty was some sort of a, presentation, which is maybe not directly related to the patient's acromegaly, but maybe the physical features has caught the attention of the treating doctor. Which of the following investigations will confirm the diagnosis? Not for the breathing difficulty, but for the acromegaly. So acromegaly, I've taught you in my lectures regarding the screening test and confirmatory test. The screening test is serum levels of IGF-1, which is elevated, and confirmatory test is the 75 gram oral glucose growth hormone suppression test. So in case of acromegaly, you will not have suppression of growth hormone. And if at all there is some sort of a suppression to a level less than 0.4 nanogram per ml, it will exclude acromegaly. So this question, a non-suppressed growth hormone on administration of glucose, is going to be the answer for this question. Okay, right. Coming to next question. A teenage girl with a non-type 1 diabetes mellitus currently on insulin therapy presents to the outpatient department with severe dehydration after skipping her last insulin dose. The random blood sugar is markedly elevated, 720 milligram percentage. The serum sodium is 126 milliequivalents per liter. So there is hyponatremia. Serum potassium is 4.3 milliequivalents per liter. So type 1 diabetes, again with a hyperglycemic emergency. Okay, so the patient has presented with a hyperglycemic emergency. So since it is type 1 diabetes mellitus, likely to be either a diabetic ketoacidosis or even HHS. DK is more common in type 1 diabetes mellitus. But that's not what they're asking. It's that what is not a part of the management. Okay, now, we very well know that in the management of diabetic ketoacidosis, replenishment of the ECF volume is important, and for which normal saline is definitely appropriate. So that is not going to be the answer. You have to give normal saline. And what about IV insulin? Insulin is also an important part of the management, especially with blood sugar being, skyrocketing high. And coming to potassium monitoring, when you administer insulin, although the potassium levels is normal now, it's not that potassium monitoring is not required. When you go for an IV insulin administration, what can happen is that there is a chance of redistribution of potassium from the ECF to the ICF, resulting in hypokalemia, and because of which you will have to monitor the potassium. What about 3% saline? Don't you think it is required? The patient is having hyponatremia. See, this sort of a hyponatremia is usually a dilutional hyponatremia. So once you correct the fluid deficit and once you give the insulin as well, this is likely to be corrected, okay, auto-corrected, and hence there is no specific, need to give a 3% saline. In this particular case, option A is going to be the answer. In a patient with Addison's disease, what is the underlying cause of skin hyperpigmentation? Again, a very simple question. It is elevated ACTH levels. So elevated ACTH acting on the melanocortin receptors on the skin, resulting in stimulation of the melanocytes and producing hyperpigmentation. I've discussed this in my lectures also. What about increased cortisol? We know that Addison is not increased cortisol, it is decreased cortisol. Addison is not increased aldosterone, it is decreased aldosterone. Iron deposition is a feature in case of hemochromatosis. That is not going to be the answer. Okay. Coming to next question. A patient presents with complaints of salt craving, generalized hyperpigmentation, and laboratory findings of hyperkalemia and metabolic acidosis. What is the likely diagnosis? Most likely diagnosis. Addison's disease, Cushing's syndrome, Conn's syndrome, pheochromocytoma. So when you look at the question and options, it is actually best relating with the Addison's disease here. Because in Addison's disease, you can have salt craving. And what is the reason for salt craving? Aldosterone deficiency. Okay, so you can very well explain the salt craving, the hyperkalemia, and the metabolic acidosis, all these three by aldosterone deficiency. And again, the excess ACTH responsible for the generalized hyperpigmentation, right? So that is what you will see in this particular case. Answer is option A, Addison's disease. Next question. A 45-year-old male presents with headache, palpitations, and sweating. Laboratory test reveals elevated vanillyl mandelic acid and metanephrine levels. So we are possibly considering a diagnosis of pheochromocytoma. We are possibly considering a diagnosis of pheochromocytoma, considering the clinical presentation and the lab evaluation. What is the preferred drug for pre-operative and intraoperative management? Straightforward question. Answer is phenoxybenzamine. And I've always told you, avoid beta blockers before giving alpha blockers. If you first give beta blocker, there is a chance of unopposed alpha action resulting in a pheochromocytoma crisis, a hypertensive crisis, and also clonidine, not a preferred agent for the management. Answer is option A. A boy with chronic kidney disease with anemia, what is the most appropriate treatment? It is going to be darbepoetin alpha. You will have to go for erythropoietin as a part of the treatment. Now, at least some students would have got confused, sir. Could this be iron? See, in case of CKD, it is very important to check serum ferritin. CKD with anemia. If they had asked me what is the next step obviously is ferritin. And if the ferritin levels are found to be low, then along with the erythropoietin, you have to give iron. But there is no mention in the question of a reduced serum ferritin for which I am taking it to be normal. So in that case, the answer should be option B, darbepoetin alpha. Okay. Next question. 12-year-old child with chronic kidney disease is admitted for evaluation of bone pain and growth retardation. Laboratory investigations reveal a serum calcium of 7.2 milligram percentage, serum phosphate of 6.3 milligram percent. So calcium is reduced, phosphorus is increased, alkaline phosphatase again slightly on the upper limit, elevated PTH levels, X-ray shows metaphyseal dysplasia. So you're having a patient with chronic kidney disease with MBD, that is mineral bone disease. And the question is asking about the management of this condition. So option A and B are eliminated because phosphate binders are useful, but alone, no. I think you have to consider correction of the calcium as well. Calcium alone without phosphate correction, again, not advised. Calcium supplements with phosphate binders, yes, that is a possibility. Okay, calcium supplements with phosphate binders. At least some students have, gone for option D. I'm not saying option D is wrong, absolutely, because oral calcium with vitamin D is important, definitely is a part of the management itself. But when you look at the question overall, this management strategy, which is option D, is again only correcting the calcium component, that is not addressing the hyperphosphatemia. And we know that in chronic kidney disease MPD, hyperphosphatemia is one very important step that occurs in the pathogenesis of MPD, because of which I would prefer option C as the best answer for this case. Okay, right. Coming to the next question, HIV positive patient with a 2-week history of fever, cough, and weight loss, diagnosed with tuberculosis, appropriate approach to treatment. So always remember, when you have an opportunistic infection, first treat the opportunistic infection and then start ART, at least in many scenarios. And the reason is because it can cause some complication that is known as IRIS, which is immune reconstitution inflammatory syndrome. So what you have to do in this case is start ART 2 weeks after initiating ATT. Because if you simultaneously start ATT and ART, there is a chance of a reconstitution of the inflammatory syndrome, which can trigger IRIS. So answer is option A. Coming to next question, patient with tuberculosis and HIV is found to be rifampicin resistant on CBNAT. What is the appropriate management and what is the most likely associated complication? See, if you look at the option itself, the only regimen that is actually, in the NTP for this particular scenario is going to be option A. That is the BPAL-M regimen. Okay, BPAL-M regimen. So, just look at the latest algorithm on the management of the tuberculosis, and you can see here the newer regimen, which is the BPAL-M regimen. So what has been mentioned here is the BPAL-M regimen. Okay, so levofloxacin, INH, ethambutol, pyrazinamide, again not preferred regimen. INH, ethambutol, pyrazinamide, streptomycin. Nowadays NTP does not recommend it. Isoniazid, levofloxacin, clarithromycin, ethambutol, again no. So the regimen recommended is this, and the second part is what is the expected complication. You can have iris development, which I've just told you as well, especially patient with HIV also having TB, there is a chance of development of immune reconstitution inflammatory syndrome. 24-year-old abattoir worker who came with complaints of fever and headache for 1 week with red eyes and reduced urine output. So abattoir worker, fever and headache. Okay, red eyes. So there is some sort of a conjunctival suffusion in this case. Reduced urine output probably because of a renal involvement. Raised serum bilirubin levels probably because of hepatic involvement. And when you have this sort of constellation of features, you're considering a diagnosis of Weil's disease. Correct or not? Yes. Coming to the next question, 40-year-old male with a known history of gastroesophageal reflux disease continues to experience regurgitation and bloating despite several weeks of PPI. His physician is considering switching to a medication that enhances lower esophageal sphincter tone and improves the gastric empty. Which of the following would be the most appropriate? So GERD patient already tried on PPI, you don't want to again try on another PPI, right? Omeprazole. Not just that, what have they given? Some drug that enhances lower esophageal sphincter tone and improves the gastric empty. So in GERD, there is always a chance of reflux. So you've got to give a drug that is increasing the LES tone, right? And prevent the reflux. And eventually they're actually asking for a, what is a prokinetic drug here? So out of the options, what is a prokinetic drug? Metoclopramide. Vonoprazan is a potassium channel blocker, relatively newer one. And sodium alginate is acting by forming a physical barrier, but the mechanism of action is not what is referred as in the question. The answer is metoclopramide. Which of the following causes of factor 9 deficiency can be improved after vitamin K injection? So hemophilia, hepatitis A, biliary obstruction, thalassemia minor. Factor 9 deficiency. Okay, so anyway, thalassemia minor is not related to any clotting factor deficiency. I'm eliminating. So there is some sort of an improvement after vitamin K. Okay, the clotting times are improving. Maybe APTT is improving. So what could it be? Hemophilia is not going to. It's a clotting factor deficiency. Even if you give vitamin K, what is going to happen? So it's not going to be hemophilia. And even hepatitis A, where there is a dysfunction of the liver. Again, if you give vitamin K, nothing is going to happen. But in biliary obstruction, I've told you in the module on the malabsorption as well, there is some sort of biliary obstruction that takes place, right? there is some sort of a biliary obstruction. When there is a biliary obstruction, there can be fat malabsorption. There can be malabsorption of the fat soluble vitamins like A, D, E, K, and the vitamin K dependent clotting factors are 2, 7, 9, 10. So when you have got biliary obstruction, there is a chance of a vitamin K deficiency, and subsequently there can be clotting factors like 2, 7, 9, 10 that can be affected, for which you can definitely give vitamin K injection and there can be improvement as well. Answer is option C. Which of the following IV fluids, when given in large volumes, is most likely to cause hyperchloremic metabolic acidosis? Is it normal saline? Is it Ringer lactate? A D5 with water, DF5 with normal saline? So IV fluid that can cause hyperchloremic metabolic acidosis. Hyperchloremic. The normal saline, the chloride is 154 milliequivalents per liter. Okay. Ringer lactate comes to around approximately 109. So this is almost negligible. D5 with water do not have much electrolyte. So I'm already eliminating that option. Now D5 with normal saline. Okay. Anyway, 109 I'm eliminating. 154 is definitely above 109. D5 with normal saline theoretically also has almost similar to that of the normal saline. But both these were in the options. Now, if you look, fluids given in large volumes, D5 with normal saline is usually not given in large volumes. It's a maintenance fluid. Normal saline can be given in large volumes. So among the two options, the better is option A, normal saline. And when you give normal saline, you've got chloride in the concentration of 154 milliequivalents per liter. And when there is so much of chloride, we know that so as to maintain the electroneutrality, that is, the anionic compartment should be the same. What should actually happen is, you see here, this is chloride. Okay, so what happens is the bicarbonate, in the body, that can be eliminated. Okay, so as to maintain electroneutrality, when you give excess of chloride, not only will some chloride go, but some bicarbonate also will be eliminated. That can predispose to acidosis. So excess chloride and bicarbonate elimination would result in a hyperchloremic metabolic acidosis. So that is why option A is going to be the answer for this particular question. Okay, right. That's it. We come to the close of this discussion on NEET PG 2025 medicine questions. See you later.